We were asked to talk about screening, and I was asked to talk about screening, health screening by the patient participation group, I think, in response to some questions that the PPG had received from patients and others around. This will therefore be a 45-minute-ish lecture on health screening, what it is, what we do, whether what we're doing is sensible or not, and whether we should be doing things that we're not doing or not doing things that we're not doing. That sentence will become a bit more clear as we work through the processes. There will be a short stop in the middle of it to do some maths. Go us. Because we're going to have to do a bit of statistics if we're going to get some of the concepts that are going on here. If the maths gets confusing at any point in time, please shout. Excellent. Right, so let's move on to the first bit. So now, screening criteria. Health screening has been done for a very, very long time. The first real scientific studies around health screening come out of papers produced by Wilson and then by Junger. Wilson was American, Junger was European, he was, I'm going to say German, he was published in German. Could have been any of the countries that speak German. Their papers were brought together and published by the World Health Organization in 1968 and published 12 criteria that good health screening in the world should attempt to undertake. And if you can meet all of the 12 criteria, the Wilson-Junger criteria as it became known, then you have a good health screening program. That has been escalated and now sits at 20 criteria for a good health screening program. And actually most of those additional bits and pieces is stuff around money and then an additional 4 or 5 around medical genetics, which has come on, of course, significantly since 1968, when they couldn't have told you exactly what DNA was and what was going on with it because they didn't know at the time. So a lot of modern medicine has added some additional bits and pieces onto it. But what we'll try and do is to work through these. Effectively, you can group these now 20 rules down into 5 sets of rules. The first is the condition that you are screening for. It is, now if I press the button, I should go on to the next slide. There we go. In order for us to screen for a medical condition, that medical condition must be important. It kind of makes obvious sense, really. There's no point in screening for something that actually isn't that important at all. In order for us to screen for a medical condition, we need to understand the condition we are screening for. There is no point in screening for something that isn't fully understood. We don't, for instance, screen for migraine because we actually have very little idea what a migraine headache actually is and what's going on inside the human being. So we can't screen for people who might get them because we actually don't know what it is. If we're going to screen, the screening now, and this is where one of the new ones comes in, the screening must have a cost-effective intervention associated with it. If you can't afford to treat the illness that you are screening for, there isn't a lot of point in screening for the illness in the first place. To some extent, these are applied common sense, so you'll pick that up as we go. The test. The test that we are using for health screening needs to be simple, safe, and precise. That is easy to say. It is the human body. It's not quite so easy to do all of the time. But for a good screening program, the test must be all of those things. The values of the test must be clearly understood. If you're going to do a test on a human being and get a result back, especially if the result is a range, say between 0 and 100, what do those numbers actually mean? Modern medical science will enable us to do all sorts of tests on all sorts of human beings and produce all sorts of numbers as a result of those tests. The number isn't of any use if we don't know what the number actually means in the first place. The cut-off levels also need to be clear. So once you've worked out what those numbers actually mean in relation to the human being, what is a good result, a negative result, and what is a bad result, a positive result, and where are the cut-offs? And those cut-offs need to be clear-cut, positive and negative. Screening tests will not work if there is a grey area that sits between those two sets of numerical values, because then there will be no obvious plan as to what you do with the individuals sat in that group. And the test also needs to have agreed actions upon the positive results. So the healthcare profession as a whole needs to agree that everybody is in line with the fact that a positive result leads to this action. If there is disagreement across the healthcare profession as a body that that is what happens, then there is no point in screening for that test being present in the patient, because then you'll just end up with second, third and fourth opinions amongst doctors disagreeing with themselves. We're really good at disagreeing with ourselves. There's a doctor in the room, a retired doctor. We're quite good at disagreeing with ourselves, aren't we? Yeah. That disagreement has to be squashed before you start screening. The doctors or the nurses or the healthcare professionals involved in it all need to agree that we are on the same page with this. The intervention that we are going to be doing as a result of the screening needs to be effective in pre-symptomatic persons. Screening is all about identifying an illness in somebody without any symptoms, an individual who hasn't complained of an illness. So you're taking somebody with no symptoms and you are screening for the illness in them. So therefore, we need to have an intervention which is effective in people who have no symptoms of the illness. If we don't, there's not a lot of point in proceeding along the pathway. And the treatments that the people are going to be offered, and there may be a range of treatments, but there must be treatments that the individuals are offered, and those treatments need to be evidence-based and agreed by the healthcare professionals and the scientists as a whole. If we can't get agreement as to what the intervention should be, again, there's no point in going down the process, because you're just going to end up with individuals confused about where they're going to end up. So let's go on to the next one. Oh, hello, that side. Press button, there we go. And then the program. I've used some abbreviations here to fit everything on the screen. The screening program must be based upon randomized controlled trial evidence of reduced morbidity in the population. So that means that a randomized controlled trial has shown that if you screen the population, you reduce illness from this problem in the population. The randomized controlled trials also need to demonstrate reduced mortality in the population. So fewer people need to die of the illness in the screened population than would do in an unscreened population. So a randomized controlled trial, for those who've not come across them before, is the gold standard evidence base in these situations. For screening, it will just be a straightforward two-armed trial. So you would take a population that would have no health screening. They would just carry on as they normally would with normal healthcare, and a population will be selected for screening to see whether you can make a difference. Those populations will be matched up to make sure that you're screening for the same things in the same populations, and they need to be large enough to be able to do good statistical work with those populations to check that you are actually making the differences you think you are making. I'll come back and explain a bit more about how that works in reality when I look at some of the specific screening options that are available to us. But randomized controlled trials are key if you are going to get screening right. And you need one that shows you that there is reduced sickness in the population, and one that shows you there is reduced death rate in the population. And if you can't, now that doesn't have to be the same trial. Some of the studies actually are specifically set up to prove one thing and some studies to prove another, but you must have those two available from different RCTs at the least. The program must be clinically, socially and ethically acceptable to the population that the screening program is running in. We'll talk about some of those bits and pieces when we come up against some of the current standards and some of what can and isn't done at the moment. But effectively, all of the clinicians need to agree that this is acceptable. The society in which you're running it needs to agree that running this screening in that society is suitable for them, and it must be deemed ethically appropriate. Usually that's run through ethics committees, but it doesn't have to be. The society as a whole must just generally agree that this is ethically on board. Those comments we will come back to, because there are some, is that ethical or not, in the screening that we're currently doing, even before we move to what we could do. The benefits need to outweigh the harms. That's a stonkingly obvious statement, but it's made there to make it blindingly obvious. If you are going to screen for a problem, you need to be able to show that the screening program will produce more benefits than it will produce harms. And of course, and this is one of those of the extra, so this is one of the extra 8 that's been lobbed in, it needs to be cost effective. Somebody's got to pay for it. And then you've got to implement the program. So this is the last group of them. So we will need to demonstrate during implementation that there are optimized outcomes. So this is the full journey the patients have taken through screening and treatment if they need it is acceptable to the patient, that the patient is well, happy about going through it. Some of these illnesses are quite potentially serious, so that doesn't quite work in the way I mean to, but the patient has gone through the process as a whole and has come out of the end of the process and has agreed throughout that this was the right thing for them. So we need optimized outcomes throughout, and those are patient-centered outcomes that need to be optimized for the program to run. There needs to be no other more cost-effective option. There's no point in choosing to do the expensive thing, especially in this country when all the screening is paid for by the taxpayer. If there's a cheaper way of doing it that isn't screening, we should be doing it the cheaper way that isn't screening. Staffing needs to be adequate to do it. There's no point in setting a screening program up to fail because you haven't got enough people trained to do it. And for some of these tests, that is potentially problematic. Information available to patients needs to inform the consent of the patients. So the program implementation needs to include patient-centered information so that those entering a screening study understand what it is they are entering into at the start of the process. And if they don't want to be screened, they understand how they opt out and what the consequences are. But individual persons must be able to make informed consent to access screening, and the information must be available for them to do that. And we need to be able to justify decisions when public pressure comes along around the screening program. Classically, that comes around extending age groups of screening program. We see this quite a bit with some of the programs where people will say, I'm 75 and I'm no longer called for screening. That's because the screening program ended when you were 74. So you're not called anymore because you're not 74 anymore. That's the numbers. That's what the evidence has shown. That's what the screening was set up to work around. If we are going to sensibly respond to these individuals as to why they are no longer in the screening program, all of that information must be clear and readily available. And it must be accurate and correct. If we cannot back that decision up, we shouldn't be making those screening decisions in the first place. We, the scientific and the medical profession. But the science and the medicine must be clear that it works in this age range. Everybody must agree that it works in that age range, and therefore everybody can back up the fact that that is the age range, because there will become pressure to move the age range a bit here and a bit there from both the public and occasionally from politicians who sometimes don't quite understand how screening works. That's my polite view of it anyway. So that is clear that must be part of the screening criteria. So that's just the repeat of where we were. So those are the screening criteria that we've just gone through there, just repeated. So that was the first slide repeated again. So let's try something. Yeah, we're on time. Sweet, super. Let's try something slightly more clever then than just labeling common sense with a list of bullet points, which is kind of what we've done so far. We're going to try some maths. We might even try a bit of statistics here. Let's see what we get to. We'll concentrate on the test first before we move on to some of the other bits and pieces, because that often is the bit that informs whether screening should even go ahead to a randomized control trial or not. There are common terms used statistically when assessing medical tests. Two of them which will come up over and over again are the words sensitivity and specificity. Sensitivity is the ability of a test, if negative, to predict that the disease is not present. Specificity is the ability of a test, if positive, to predict that a disease is present. Some medical tests can be very sensitive. A negative can be absolutely crystal clear you don't have the illness. That has its uses. I use tests every day in medicine with patients who are ill to demonstrate they don't have a specific disease making them ill. Dead handy to be able to do that. I can specifically test with patients who are sick to work out if they specifically have an illness, because there are tests that say, if this test is positive, you definitely have an illness. The same test is rarely both sensitive and specific. And when a test has a range of possible values, that becomes even more cloudy, because you can move what is considered normal to make it more sensitive and less specific, or less specific and more sensitive. Because if the test has a range, you can shift that range up and down. Let's try and see if we can demonstrate how some of this might work out. We're going to try and draw some stuff on the board. Let's see if my pen works. Thankfully, I did some numbers earlier, so I don't have to make the maths up on the fly. Sweet. So what we need is a grid. Let's see if I can fit everything in here. So and there, we'll need there, and we'll need that there. Sweet. And then, well, how should we do this? Like that. There we go. Sweet. Super duper. So if we have a total population that's being tested here, people probably can't see this on the video. I'm sorry about that. We have a test that we are doing, and we have a disease an asymptomatic disease that we are screening for. If the disease is present, they'll be in this column. If the disease is absent, patients will be in that column. If the test is positive, they'll be there, and if the test is negative, they'll be there. So total population is 100, say here. This is the test, so you could have 80 that are positive and 20 that are negative. The disease down here could show you that 5 people have the disease and 95 don't, for instance. What you will find when you fill the grid in is that the true positives end up in that group. This one will be the false negatives. This one will be the false positives here, because it's tested positive, but the disease isn't present. And this one here is tested negative, and the disease is definitely not present, so that's a true negative. So those are the 4 possible outcomes that you can get from a test.
You make that one false positive.
Oh, I've missed that one there. I've missed a plus. There we go. Thank you very much. Well done. Good spot. I like that. Audience participation. We're getting there. The point here is that a test is not 1 or 0. It's not a binary choice. It's not on or off. Whenever we're performing a medical test in this situation, there are 4 possible outcomes from the test that we are trying to juggle the numbers around to get these 4 in the right space. And if you can't label all these in the right place, you don't have a test that will meet the screening criteria, and therefore you don't have a screening program. Everybody with me so far? Excellent, super duper. Let's try and put some numbers on this. So I'm just going to try and draw the same chart all over again, but this time actually just put some numbers into the spaces. So that's the same grid as we had before. Here is our test. Here is our disease here. So let's assume that this test is a poo test looking for blood that has a 67% sensitivity and a 91% specificity. So it's not very sensitive, its negatives are not very good, but it's very specific. Its positives are likely to find you the illness that you are looking for. If we have a population, I've done some maths here, if we have a population of 2,030 people, a randomly sized population, just to mean that I don't get a whole bunch of decimal points when doing the percentages here, what you will find here, if you are looking for bowel cancer with a poo test, positives here, negatives here, positives here, negatives here. So this test we decided was, I'll put the numbers up in a moment. So 20, 10, 180, there we go. Super, I must have been watching too many darts to get to 180, mustn't I? So, if this test is 67% sensitive, I've run out of pieces of paper here. I'll write on the bottom. I should have planned this one out a bit better. And 91% specific. Yeah, there we go. What you can see from this is what you would expect to see, that if the disease is present and the test is positive, we're picking up 20 people. So these are the true positives. These people have had bowel cancer and we've successfully picked it up on the test. However, we've had a negative test result that has missed 10 cancers. We've had a positive test result which has resulted in further investigation but has been proved to not find cancer in 180 individuals. So we've tested 200 individuals and we found 20 cancers. We've missed 10 cancers, but we've excluded cancer successfully in the vast majority of patients, 1,820 patients. The test here is, of course, a camera stuffed up the back passage with a good look around your colon to see whether you've got cancer. That has to be preceded by a series of clearing out your colon to make sure there's no poo in it, otherwise you can't see what's going on inside the back passage. That is as comfortable for the human being as you can imagine it would be. People don't look forward to these. It's not, woohoo, yay, it's colonoscopy day today. It's not the sort of thing you put a big star on the chart about. However, that's what the test is we're talking about. We're doing that test 200 times, according to this data, to find 20 people. And we're missing 10 cancers because we got negative results back on 10 people who had cancers in this population. So the question, therefore, is that is the test, is how does that meet the other criteria? We know that bowel cancer has is a condition that we understand, that we can test for, colonoscopy works, and we can treat because surgery and chemotherapy works for bowel cancer if you find it. So we know this is a condition with a pathway we can put people on and that we can get the treatment right on.
Could I just ask, the 10 that weren't picked up, will they be picked up possibly at a later stage by other tests? Or
Yeah. What will happen naturally to these people is they will go on to develop their cancer.
Yeah.
They will turn up to see their GP with symptoms of bowel cancer, and then we will diagnose them. They will be diagnosed with a later stage cancer than the 20 people who were found by screening. Their intervention is relatively straightforward. It might even be an intervention you can do up that scope that you put into their back passage. Sorry that this gets all rather personal and people's insides. This is medicine after all. It might even be that you can do the treatment that way. They don't even need surgery. They might get to the point where they are so early the diagnosis they don't even need chemotherapy. These people are going to have late stage diagnosis. So they're going to need more aggressive therapy with worse outcomes associated with their treatment. Sarah?
So the bowel cancer screening, though, starts off with the poo test.
Mm-hmm. That's the poo test. Yeah, keep going.
How many people have a positive poo test out of the 2,030 people?
So if you look at the positive, it will be the sum total of these two, so that'll be the 200. Okay. So 200 tested positive. All of those 200 went for a camera, because I'm assuming for these numbers that all of them engaged with the process and went for the camera test. I know that there will be some dropout, but we'll assume for the maths to make the numbers not go completely wonky. So yes, and therefore you're doing 200 camera tests, 180 are normal, 20 of them have got early cancer that needed intervention.
So sorry, only the 200 had a positive stool test?
Yep. These had a negative stool test, so these 1,830 had a negative stool test, of which 10 of those actually had a cancer all along and we missed it. And yes, these would have been found out 5 years down the line when they presented with classic symptoms of a colon cancer. Yeah.
But they could you get about the test over 2 years?
Yes.
So they could actually be picked up 2 years later?
Yeah, so now you're getting there. So this is the next step, but bang on, well done. That's the next step. So if that's our understanding of this, what do we change to make this better? So my question would be, is this test acceptable to be put into a screening program as it stands, as I presented the numbers here? I suspect what I'm hearing from the room is that this isn't good enough. The medical profession would agree that this isn't good enough, which is why it took a long time for us to get round to using the poo samples for bowel cancer screening, because we were looking at these numbers and we couldn't make them work. The amount of testing for positive tests that was required to pick up the small number of early cases compared with the number that you were missing just wasn't making the process cost effective, ethically acceptable, socially acceptable. We couldn't staff it. You can see how it started to fail all of the criteria. So we started to try and manipulate these numbers, and you're right, there are several ways we can do it. Firstly, we can change the sensitivity and specificity of the poo test itself, because it is a range. It starts off at 0 and it goes up to about 500. And you can move the dial. So you can adjust the number of positives you will get, and you can therefore reduce this number by making the test more sensitive. The problem is, what you will then do is increase this here. Most importantly, you will increase the false positives. And as soon as we started to dial that in that direction, you started to see there being too many tests going on here, and again, less cost effective, inability to staff it. If I fill up all of the endoscopy suites with cancer screening, who's actually doing the endoscopies that we need to be doing every day for patients who are sick, because there are other reasons to be doing them, not just cancer. So what happens to the rest of it all? It all started to fall apart. So one of the other things you can do to manipulate the numbers is you can do the test more than once. The more times you do the test, the more times you will dial up both the specificity and the sensitivity. So one of the things we can do is repeat the test, which is exactly why you repeat the bowel cancer screening test more than once. So you get it, and then you get it again, and then you get it again. Firstly, you could develop a cancer further that wasn't there the first time, so you could develop a cancer and therefore pick up a true cancer. And secondly, because if you missed it the first time round and you do the test again, you might well pick it up the second time around. And actually the statistics show that quite nicely, especially with the current version of the test. I mean, actually the numbers what I've presented here, the numbers fairly close to the old school fecal occult blood test. So that used to be one that I used to use when I was younger as a doctor, and our doctor present in the room here would probably have come across an awful lot when they were younger and working as a doctor. That's moved to a fecal immunochemical test, which is much, much more accurate and has a much more granular range associated with it, enabling us to pull that range up and down as we need to meet the needs of the screening program. And that's what changed, enabling bowel cancer screening to occur, because we could manipulate that and the frequency of testing to make the numbers add up better. Does that make some sense to everybody? Are we getting the maths here on that one? So that's why the test is important in order to get things moving. And we may come back to that one a bit later when we talk about things we don't do. So that's the bit about testing. Yeah, go for it.
Based on what you said, I presume you don't just do a colonoscopy because of the cost.
Okay, so that's a really good question. Yep, okay, so why bother with all of this testing at all? Why not just do colonoscopy on everybody? You're right, there are several reasons for this. Firstly, it's not just cost. One of the issues is staffing. To do colonoscopy, you need to be trained to do colonoscopy. You need to do them regularly, and you need to keep doing them. It's actually quite a tricky set of skills to learn how to do. I've done a couple of hundred myself during surgical training. It's not the easiest thing to pick up. Most people can learn to do it in the end, but it is a practical skill you need to learn how to do. So one of them is that estates and buildings and cost of all of that then starts to rack up. There were some issues around safety. Colonoscopy has a risk associated to it. It can cause harms. A poo test can't cause any harms. It's just some poo scraped onto a stick that's sent off in the post. Colonoscopy can hurt people if it's done wrong. That's getting better. The harms are coming down with time and with new equipment and new materials and new processes. Medicine is getting much safer at doing it, but it's not a zero risk option. As a result of which, if you took the entire population and sent them all for a colonoscopy, you would make almost as many people sick as you picked up cancers.
Which, of course, is the American system.
I believe that some states in America do that, yes. Screening in America is not a federal program. I believe screening in America is state-based. Have you got any Americans here? Or anybody who's lived in America? You lived, okay.
Certainly a lot of my
because
Mhm.
they have their annual colonoscopy
Yep.
after the age of 50.
Yes, I am aware that some people do line up and do that. I'm not quite sure where the numbers come from. In terms of state-based programs, I've not seen any evidence from the public health organisations inside the states that pushes a particular program or another. I believe most of it's funded by the insurance companies.
Well, yeah, so the whole screening criteria, funding is a huge issue.
Yeah. No, it's a massive issue. You're quite right. And the insurance-based healthcare system will struggle with screening. That is one of the, if you run through those screening programs, you will see this repeated, that they struggle to work out how to actuarially cost out a screening program. Some of them make sense, and the actuaries will be able to say this is definitely worth doing, and the health insurance companies will pay for it because it makes sense, because it makes people less ill. But you've got to make a very strong case for it in order to be able to get that through. And of course, in the US, it depends whether you've got health insurance or not, because those require Medicare and Medicaid don't seem to get any screening at all, as far as I'm aware. I don't know whether. The criteria we are listing here is the World Health Organization criteria. This isn't, with the UK chooses to apply the WHO criteria for screening and has always attempted to do so. That is a political decision. The politicians could choose not to do that, but they've always chosen to try and apply the WHO criteria for screening. A lot of this just depends upon the nature of the test concerned. A lot of the results we get back are not a standardized range, but are a weight. So they are, especially if you're looking for a specific protein or chemical, what you're getting is milligrams. So you're seeing that variation because you're getting a number of it. The fecal immunochemical testing is exactly the same. The FIT testing we've replaced this with is another one that measures the amount of a thing. And so therefore it's effectively weighing it, and that range is 0, there is none present, to 500, I can't weigh anymore because my scales just broke. How are we doing for time? Oh, we're doing okay. We'll move on to the next one. So what I've got now over the next 2 slides is a list of what we currently do inside the NHS. NHS screening, which is interesting because it's all badged as NHS screening, by the way, is not paid for by the National Health Service. It's paid for by the UK Health Security Agency, what used to be Public Health England, because these are public health programmes, not NHS programmes. The reason they've got the logo that says NHS on the top of them is because everybody trusts the NHS, so they stole the logo and stuck it on the top of the page. But it's actually not an NHS programme at all. They might use NHS facilities. They might, for instance, pay me as an NHS organisation to do some of this, but this is additional work on top of what we're paid to do. So it's actually a public health funded screening programme, although they're all badged as NHS screening. The first one is the abdominal aortic aneurysm screening program. Some of you may have be aware of this one. There is a big artery, a big blood vessel inside your abdomen, which can, in a small number of people, grow bigger and bigger and bigger, and if not treated, may burst and they die as a result of it. For a long time, right from when I went to medical school back in the 90s, the concept of screening for abdominal aortic aneurysms has been on the table. We have gone round and round and round this one to try and get it right. We just about have the numbers to make this function now. It's taken a very long time not to get the test right. The test is an ultrasound scan, which just measures the size of the blood vessel in the tummy. That's easy. We've been able to do that since the 1960s. That's not difficult to do. The problem is, what do you do about the numbers you get back again? And that's the bit that's been a struggle to work out where we're at and what we do. The agreement that's moved it onto the screening program about 10, 15 years ago, I think, was that they managed to put together a criteria which says if it's size A, it's normal. If it's size B, it's moderate. If it's size C, it's severe. I can't remember the exact cutoff of the numbers now, but they're set into these groups, and each of those pathways now has a definitive, evidence-based, RCT-proven treatment program associated with them. And now, because we can move people into the treatment program, we can do something with it. Otherwise, we were just telling somebody you've got an aneurysm, you're going to die in 5 years' time. Well, that isn't ethically appropriate, so we didn't do it. So now we can do something about it and see what we can do moving forward. So that's why the abdominal aortic aneurysm has come around. We have the scanners in with us, so they come to the White Horse Medical Practice and they do the scanning in the practice for the men that are invited to the programme. It's only men over the age of 65, by the way, that are invited to this. The illness is too rare in women to be screening for. It doesn't show up the numbers. You will end up with a complete mess if you try doing that as well. So it doesn't work cost effectively for women. It only works cost effectively for men because there's a population large enough to do it. But yes, they come up to the practice and they do the scans in the White Horse Medical Practice. I think they were there last week, actually. I'm looking at... you didn't see them in the building, Sarah? No, okay. No, I think they were up there last week, so I think that one's fine. So breast cancer screening. Everybody's heard of this one. They always make a fuss when the breast cancer screening van turns up and parks in the car park of the White Horse Medical Practice. We haven't got enough parking spaces as it is, and they turn up and take 8 of them all in one go. Woohoo, go them. So breast cancer screening. This is an interesting one for discussion. Breast cancer screening has been around for a very, very, very long time. It's clearly, obviously, for women. It starts at 50, it ends at 71. This is one of those where pressures have been seen to extend the age range, both bring it down lower than 50 and take it up above 71. This is one where everybody's had to be clear that the maths do not work if you start to extend the age range beyond that. So it has to be in those age ranges because it's the only way that all of those screening criteria are met is if that is the age range that you work within. And multiple studies across the world have shown that to be where we're at. One of the problems we have with the breast cancer screening program is that the first mammogram done has a high false positive rate. So about the pickup rate from a positive mammogram from the first woman, so the woman who turns up when they're 50, going to their first mammogram, about 3% of the positives turn out to actually be an early cancer. 3% of the positives turn out to be an early cancer. So 97% of the first mammogram positives that women go through are false positives. Yeah, that's a thing, isn't it? In order to resolve that, they then need to go to a specialist breast cancer unit and have a repeat mammogram because 2 tests are better than 1, which is what we were talking about earlier on. And then they have a 3-dimensional mammogram, which is one that takes the images from different angles all at the same time, and an ultrasound scan and a physical examination. It's referred to as the triple test. So it's the 3-dimensional test, it's the ultrasound scan and the physical examination.
Can I just ask a quick question?
Yeah.
Developing that down. So now that we read that breast cancer is becoming more common in younger people, and you've just said that we've realised that this is the age tab and it doesn't need changing. Do we look at that? Do we look at the men who are also, but obviously I assume there's not a high enough percentage.
Correct.
Yeah. Test, but they can also get it.
Yeah, but men can get breast cancer. It is much, much rarer, and you can't make the cost effectiveness work for anyway. Mammogram doesn't work either, so you would need a different test. So there's no test that works. It isn't cost effective. There's no known treatment that really works for men because their breast cancers are slightly different to women. The whole thing just, as you go down the list, it just fails everything down the screening program for men. There is a constant re-evaluation of the breast cancer screening program for women and the age at which women enter into the program. The problem is that one I've just mentioned to you, mammograms don't work well in a 50-year-old. They work even worse in a 45-year-old. The number of false positives you're going to get will be about 99.5. So you're going to pick up about 1 woman in every 1,000 that you send off to specialist triple testing to see if they've got a problem. That's a massive burden on the screening program. And that's where the numbers start to fall into the problem. So what will have to happen for that to work is that the disease prevalence will have to go up substantially. Now, given the fact that obesity is one of the biggest risk factors for breast cancer, and the population is becoming heavier at a rate of knots at the moment, it will be interesting to see where that goes. But the more obese you are, the less effective the test is. Arg. This all starts to get clunky, doesn't it?
The more obese you are,
The less effective, yes. So the more obese you are, the more likely you are to get a false positive out of the test. So everything starts to become, the math starts to completely fall apart here. So there is a lot of work going on to try and get this better, because better is a goal that everybody's shooting for. We can't make it work. That's the summary of it. It is also worth noting in terms of, remember we talked about the RCTs have to show that those in the study, in this case women, have a longer life expectancy if they're screened than if they're not screened. That is clear. The studies do show that women being screened for breast cancer as a population will have a longer life expectancy than those women not screened for breast cancer. That is undoubtable. The evidence is clear cut. What it also shows when you dig into the data is that what you have effectively done is treat 4 women for one of those to live longer. The other 3 went through a treatment that had no impact on their life expectancy at all. We have no way of telling which is the 1 and which is the 3. So now we've got to ask the question, is this ethically appropriate? Should we be doing that? I mean, this is operations up to and including removal of the breast and chemotherapy. These are not mild procedures here, and yet we are doing 4 of them to save the life of 1 woman. Is that socially and ethically acceptable? I don't know the answer to the question. The population still wants breast cancer screening to go ahead. They still keep turning up for it, so we're going to still keep doing it. But there are some questions around all of this that do need some further assessment going forward as to exactly what groups are in it, why they're in it, and whether this is something that we should be doing on the large scale that we are.
Sorry, I'm thick here. Is save the life the same as live longer?
Yes, sorry, that's what I mean, yeah. So for the 4 people, the random 4 women, because this is just a statistical number, of course, so the random 4 hypothetical women that have been tested positive and had cancer treated, 3 of them died of natural causes at the same age they would have done so anyway. Right. 1 of them died of natural causes later than they would have done so because they would have died from breast cancer if they hadn't been treated. So 3 of them would have lived a normal life with breast cancer that would not have affected their life expectancy.
So they passed away
from old age, from something else that wasn't related to the breast cancer. So their breast cancer would not have affected their life expectancy. It may have affected their morbidity. They may have been more ill because of it, but it didn't affect their life expectancy.
So they got to their mid-80s?
Yep.
Even though they had all their treatments?
Yep.
But the one who actually had the good impact
Yep.
died in her mid-80s?
Yes. All these 4 women died at the same point.
Or 4 or 5, whatever.
Yeah, whatever the number we're choosing is. All 4 of these women died at the same point. 1 of them got to that point because they had the treatment.
Right.
The other 3 got to that point in spite of the treatment.
Right.
They would have got to that point anyway. Yeah. Yep. Yeah, interesting numbers, aren't they? Bowel cancer screening we've largely talked about. I mean, that's the poo test and the colonoscopy looking for bowel cancers. Cervical cancer screening. This is interesting because it's been in the news, hasn't it, this week? I'm not sure if people picked up the fact that cervical cancer screening has been in the news this week. We're about to change the cervical cancer screening program. This is back to, again, that point about understanding the natural course of the illness and the illness that you're trying to treat. Cervical cancer is a sexually transmitted infection. It is a specific virus that causes the cervical cancer in women. It's the same virus that causes some throat cancers in both women and men, and anorectal cancers, most commonly in men, but that can affect women as well. Usually that's men who have sex with men. The virus is now vaccinated against in school. The vaccine is completely effective. Once you've had the vaccine, you don't get the virus, and therefore you can't get the cancer, because that's what causes the cancer. So as a result of this, they are beginning to have to change the screening program because the number of cases of cervical cancer is dropping off. In the vaccinated, Scotland started the vaccination program for HPV as the virus, but Scotland started that HPV vaccination program slightly before England did for a variety of reasons related to politics. Because they've been going at it a few years longer than we have, they got some slightly longer data. Their data for their young women vaccinated in schools against HPV, that was initially the triple vaccine. We now use a quadruple vaccine, so it's now even better, but even using the worst vaccine that we started with, there have been no recorded cases of cervical cancer in those women in Scotland at all. Not one. That is a cancer cure through the vaccination program. But if that is the cancer that we've cured, Why are we now screening for it? As a result of which, the screening program is beginning to change. Currently, women have been invited, especially the younger age population, have been invited for smears tests every 3rd year. That has been changed last week to every 5 years, because you don't need to repeat the test quite so often, because we're not getting as many false negatives because there's less cancer in the population. So we've had to juggle the numbers to match those tests and the rest of it. And because we now know that HPV virus is integral to the cancer, you can also determine that women who do not have the virus cannot get the cancer. So a new screening program is about to come around, which mails out swabs for women to swab themselves, so an intravaginal swab that women can use on themselves, put in the post and send back again at home, without having to come in and see my nurse and have an invasive smear test. That's much more acceptable to the population that you're screening, of course. And because we now understand the population of the patients we're working on, that will get us a better answer. That's one of these 1 or 0 answers, by the way, because there's no range in this one. The virus is present or not present. Woohoo! That makes life a lot easier when it comes to the maths. If I can just have those, more of those would be good. So what we will see over the years is the cervical cancer screening program fading away to almost nothing and then stopping as this population of those who've been vaccinated gets old enough for us to stop the program completely. So the next generation of doctors behind me, training to be GPs, and the next generation of GP nurses behind us are going to start to laugh at all of these things we used to do with scraping wooden things around women's cervixes and then putting them onto microscope slides and then putting that's why it's called a smear test, by the way, because I used to have to smear it onto a slide and then put a slide topper on the top of it. I had to prepare it myself.
But you could bring down the age.
Yes.
As well, to
Yeah.
send the kits out.
Yeah, as you will, over the next 5 years, watch the news on this one. All of this is going to come down to a much narrower group of women that will be targeted for screening, and it will largely be those who are unvaccinated and those who haven't been screened before. Outside of that group, it will start to fade away. So watch the news over the next 5 to 10 years. You'll see all that fading away really quite nicely. And if you've got daughters, please make sure they're vaccinated before they start having sexual intercourse. I know mums don't like to think about that bit, but it happens when they get old enough. Please get them vaccinated before they start, not afterwards, because that way they can never get cervical cancer. Yeah, please, please. It's only one vaccine. That's it. It's not even a course. It's just one jab.
Sorry to interrupt.
Yeah,
What age group are you vaccinating presently then?
12-year-olds. All of them, male and female, because the boys give it to the girls, of course.
So what about those who haven't been vaccinated, who might now be in their 20s or 30s?
They can turn up at the practice and I'll stick a needle in them. Trust me, if they turn up and they say they want the HPV vaccine and they're not sexually active yet, that's the key. Because we need to know whether they've actually picked it, because there's no point vaccinating them if they've already got the virus.
So you give them a tester,
Yeah,
or do you have a test?
yes. So,
If they're sexually active,
Yep.
you give them the test to see whether they've got the virus,
got it.
and then if they've got the virus, you would vaccinate or not?
Not vaccinated. If they've got the virus, it's too late, we've missed it. They then need to be reminded that they need to take part in the screening program because they will need visualization and screening of the cervix. If they've not got the virus, I'll stick a needle in them before they walk out the building.
And then they don't need to
Yeah.
have them.
Yeah, I don't even wait to warm it up so it stings a bit.
And then they go back to the screening program.
Yeah, they can go back to do whatever they like then. Once they've been vaccinated, they can live their own life. I'm not here to tell them how to live their life. Just how to do it safely, that's all.
Do people in their 20s, do they know that they can?
It is around and about out there. It is pushed out there. It's not primarily us. We do have some in the fridge in the practice, so I can give it to patients and will do if they ask for it. Most commonly, it comes up in the STI clinics, because in the sexually transmitted infection clinics, because they can screen for HPV and get the answers back immediately, and they can also vaccinate in their clinics as well. So most of the vaccination of those who missed it at school is coming through those rather than us in general practice. We don't tend to see that many people. But if they rock up in the practice and say, I need my HPV vaccine, I'm 21 and I've never had sex, I'm going to say, sit there, don't move. That's that. Yeah. No further questions will be asked, and they will be leaving after they've had the vaccine, because it is that effective. And I don't get to, cure cancer every day of the week, so I quite like it. We've got the lighting's gone a bit weird here. A diabetic eye screening is at the bottom of the page. Diabetic eye screening is quite straightforward screening program. It's for people who have diabetes, everybody with diabetes who could potentially go on to get blindness because of their diabetes. We screen for the vessel changes in the back of the eye. If they're present, they go off the eye clinic. They have very simple, painless laser surgery on the back of their eye. It stops them going blind. Blindness cured. Certainly diabetes blindness is not something that we should see anymore. Diabetes should not cause long-term visual loss anymore in this country. We can screen for it and we can fix it, even if we can't fix the diabetes. So here, now this is going to be slightly, I'll read these out to us because we're not going to see these very well. So here are those that get slightly more edgy. The first one on the list is fetal anomaly screening. Anybody who's had a baby in this country will know that because they've been through the ultrasound scans that the midwives do. That is part of the screening program, and it is looking for anomalies in the child. Is there an agreed treatment program for this? It does depend a little bit on what the anomaly is, of course. Some of them do, some of them don't. What happens if your fetal anomaly testing turns up trisomy 21, used to be called Down syndrome? Do I treat Down syndrome? Is Down syndrome an illness? Now, I'm stood in a Catholic church hall, so I'm going to have to be really careful as to where I go with this. I'm wearing rubber-soled shoes, I should be okay. Do we terminate a pregnancy? Or don't we? Is this an ethically appropriate screening to be doing with pregnant mums? There is a big debate, of course. And this isn't one that we're going to solve here, but this is one of the screening programs that's kind of crept up over a period of time without actually really looking at the randomized control data and ethically whether it's appropriate. We've just done it because we can do it.
Is that changed because the actual ability to see the baby has improved so dramatically to the point where you can see just about everything?
Yeah, you can see, yeah, that's it. And because they're doing the scan to help the pregnancy progress normally, and there are interventions that you might need to do if the pregnancy is failing in order to improve the pregnancy, or if the pregnancy is, say, more than one. Personal history of that one. I mean, not myself, of course, I've not been pregnant, but then there may be things that need to be done in order to improve the chances of the pregnancy proceeding successfully. So yes, as an accident of that, we now screen for a whole bunch of other illnesses in these children. And then what? Is there an agreed plan as a result of it? And that gets back to that, if there's a condition, what do you do about it? Next one, go on.
You can also plan the place of delivery.
You can plan, there's all sorts of things you can do to make the pregnancy safer. So that makes some sense. But there is also, as an accident in here, some of the things that actually start to fail the screening program, and yet we're still doing them because we can do them. Infectious diseases in pregnancy is another one. Women who are pregnant are in the large condition having unprotected sexual intercourse. That's how they're pregnant in the first place, of course. That's not news to anybody in the room. Therefore, they could be picking up sexually transmitted infections. So all women who are pregnant are offered HIV screening and hepatitis screening, and for other sexually transmitted infections, depending upon the population you're working with, it can include things like syphilis or chlamydia or other bits and pieces like that. That's a standard process that's offered to all pregnant women at the time. Now, there was some debate about this when it started, because when it started, HIV was relatively new. And we're back to the whole, why are we diagnosing someone with a condition that we can't fix? That is different now, of course, because HIV is almost entirely curable, and in this country anyway, because we can afford the cures. And horizontal transmission, that is transmission from mum to baby during the pregnancy and during the delivery, can also be prevented with the right treatment during the pregnancy. So vertical, sorry, there you go. You're right, thank you for that. The vertical transmission can now be prevented, and can be prevented for a lot of the other sexually transmitted infections as well. So now we've got the treatments, we've been more aggressive about it. So it used to be a thing that you did if the women wanted it and asked for it. Now it's just universal for everybody. Newborn screening blood spot testing. I'm not sure if you've come across these, whether your children had these when they were born, but it's a heel prick test. Blood is applied to a newborn screening thing, and a whole raft of illnesses is tested for. I think it's something like 12 or 13 of them now. They're all incredibly rare. Thankfully, these are pretty binary tests. So we're back to a 1 or 0 test. This one's an on or off test. So what they've done is they've listed all the on or off tests for all the rare stuff that kids can get that could affect growth and development that we can do something about, and they're all on the same test. So that's what the newborn blood spot is. There is a newborn and infant physical screening program. This is the newborn baby checks that babies get by doctors or midwives or physician associates now, after the child is born, and then another one 6 to 8 weeks later to pick up any physical anomalies with the infant. There's about 14 or 15 different things. It's been a while since I've done them. I don't do them in the surgery anymore, but there's a whole list of things you have to go through and screen for in those. It is interesting. The reason that this is cost effective is because, largely speaking, this is done by junior doctors in hospitals and junior doctors in GP surgeries, and as a result of which it's free, because they were there anyway. They can work a few extra hours and do a few extra tests, and nobody pays them, so we're fine. The only reason it still goes ahead is because it is effectively done for free by the junior staff in the hospitals and in the surgeries. Newborn hearing is done with all newborns, of course. And it used to be a really complex thing that you used to have to do all sorts of weird hearing tests with the baby, and now they've got this thing that they just stick in the ear and press the button, and it tells you whether the baby can hear or not. It's great because the reason that this is now advanced to all children rather than just at-risk ones is because the ear, nose and throat hearing team and the audiologist can do things with the Bahas and the bone conductors and the other devices that they've now got to effectively reverse the deafness very soon after birth. So that child can develop with some form of hearing, which makes such a huge difference to their life chances going forward. So the cost effectiveness of it is just massive, and that's why we the newborn hearing test is done in hospital, usually before they're discharged, or they're called back. If they're born in the community, they're called in for it afterwards.
Do they do that in Wales as well as England?
This is the NHS England screening programme that I'm talking about. I think an NHS Wales one was the same. I can't see any reason why they wouldn't. The Welsh usually follow the English programme.
My nephew wasn't picked up to use 3, and he's now virtually deaf in both ears.
Oh, that's unfortunate. It would be nice to pick it up sooner than that. Yeah, and we would try to. Yeah. Also, there is a sickle cell disease screening that is available on the NHS in England. That is very specifically targeted at those populations that could have sickle cell disease, which isn't our population here, so we don't do it. They do have some in Swindon. Yep, that is quite correct. Yep. Yeah. No, I don't doubt that for a moment. We have very few individuals here. I don't think we've got any on the books at the moment in the practice. Okay, so that's what I did there was show you the list all over again. The reason I was showing you the list all over again is that that's the ones we currently do. There is, of course, a very topical one that we don't do. We don't screen for prostate cancer, which is the question that always comes up in prostate cancer. This is the question that always comes up when you talk about medical screening is, why don't you screen for prostate cancer? Well, because it doesn't meet any of the conditions, is the bottom line here. Firstly, the condition needs to be well understood. It's not. There are various different forms of prostate cancer, aggressive ones which kill men, and very mild ones which make absolutely no difference to them whatsoever. We have no medical way of telling one from the other until it has obviously become aggressive. Boo. So we don't understand the condition well enough to be able to screen for it. There is no universally agreed treatment program for prostate cancer. There are multiple different treatments, but actually if you ask the urologists to all agree on the same treatment for prostate cancer, they won't do it. That's not a thing they can do. The test is a problem, because the test is something called the PSA blood test, and you'll have heard this one bounced around in the news a bit. The PSA blood test has been looked at as a potential screening tool. They have ran randomized control trials. See, we're trying. It's not that we're ignoring this one. There were 200,000 men from Bristol, Oxfordshire, including some recruited from the Whitehall's medical practice and Cambridge, in 200,000 in a screening arm and 200,000 in a non-screening arm. And over a period of time, these were studied to see who developed cancer and whether the cancers were treated appropriately or not. So the 10 years was up in 2018, kind of got lost a bit because the publications came out in 2019 and then the world came to a halt. So we kind of lost some of this data in the middle of the noise around COVID. The 10-year study showed that of the 200,000 men in the screened arm, 4.3% were diagnosed with prostate cancer. In the unscreened arm, 3.6% was diagnosed with prostate cancer. So there was an increase in diagnosis in the screened group. However, the percentage of those who died from cancer was exactly the same in both groups. So detecting those extra cancers made absolutely no difference to the mortality rate of the men they were studying. The 15-year study was released, ended in 2024 and came out in February of this year. So the peer-reviewed study came out, and this did actually show a very marginal increase in life expectancy and a statistically significantly marginal increase in life expectancy in the screened group. It was tiny. They went on to do a piece of mathematics about cost effectiveness of all of the treatments that was required to get this tiny difference. And they think to roll this out across a population, it would cost about £350 million to the taxpayer in England for a life expectancy change in men of about 6 months to a tiny proportion of them. As a consequence, this isn't going anywhere fast. The professor who wrote the study was very clear that the PSA is not good enough at picking up aggressive cancers from non-aggressive cancers. Over-medicalisation of those who would not have been ill because of their prostate cancer is too high, and the effectiveness is virtually zero, and if it is anything at all, is going to cost millions of pounds to add an extra 6 months to a tiny number of men.
Is there an argument to say that for those men that are recognised to come from families where prostate cancer is a known problem, they should be screened?
Now, that's an interesting question. As yet, the subset data within those 200,000 does not suggest that that is working. The family history and the genetics around prostate cancer, again, are not understood. And that's the gap that we've got here. Now, there might be some better blood tests coming along. The University of Bristol alongside the University of Oxford are working on some of those. In fact, we are potentially signed up at the Whitehall's medical practice to be a trial part of that. So there might be some new blood tests coming along that are more sensitive to the aggressive ones. That's helpful. And there is an issue around MRI scanning of the prostate, which might change the process again, but then you're still sitting men on an MRI scanner. That's not cheap.
That's the big study that's being run from King's.
That's the King's study, yeah. There's two, the Bristol and Oxford studies are looking for blood tests that can, so the quick, simple, easy, safe processes. The King's one is looking for anything it can ever possibly find anywhere that will make a difference. Both are valid approaches, they're just two different ways of trying to approach the same problem. So that's why we don't do prostate cancer screening. It doesn't work. And nobody has found a number or a test or a way of making it add up. You will notice that no country in the world does prostate cancer screening. Anywhere. That's not an accident. Nobody can make the numbers add up and make it work. So until that changes, we're going to be pretty much where we are with it.
If somebody comes and asks for a PSA test, do you try and argue them away from
No.
it?
I don't. I don't, and I hope my colleagues wouldn't either. What we do, because we are moving towards digital, because the government said that general practice has to be digital, what we do is we ask those men to put in a digital request for symptom-free prostate cancer screening. They then get a digital response back, which is one that we've carefully put together with a whole bunch of links to the government's, so the uk.gov.uk and to the research programme from Bristol and other places like that, with a series of links, and we ask them to go away and read it. As long as the men have read it, they have informed themselves, and they have informed consent to go ahead with testing, we will allow them to book for testing. They don't have to come back to the doctor, they just have to write back and say, I've read all of the above and I'd still like my test. In which case our care navigation team, so their receptionists in the practice, will just pick them up and book them for the blood test. So that's fine, we just ask that they are completely informed about what they're asking for, what the risks and benefits are, and they understand why this is not universally offered. If they still want it, they can have it. Yeah. At the moment, we have never found statistically that trying to identify family history has made a difference to the outcome of the screening program. Now, the one thing we haven't talked about at any length is genetics. We may need to come back and do a different talk on that. I've kind of skirted around the issue of medical genetics. The NHS, England, nowhere in England, does full-blown genetic screening. It is theoretically possible to map your DNA and increasingly possible work out what illnesses you may suffer from in your lifetime. Is that a good thing or a bad thing? Who knows is the answer to that question.
Rolling it out.
Yeah, some places are rolling it out, you're right, yeah.
I mean, it was on
Yeah.
the front page of the newspaper.
Yeah, there are some private organisations which are doing it. The NHS is not, it's got some research studies going at the moment, but they are research studies, they're not generalised everywhere. There is a, yeah.
I think I read this and thought, this is ridiculous.
Yeah, they're picking up some data from children at the moment, from newborns who are consenting to go into the screening. It is part of the RCT to see how this is going to work. It's not a universal everybody because there's a control cohort in this. So some of them are signing up to be screened but not getting screening.
And what about just like annual blood tests?
For
Anything?
if it was worth doing, we'd be doing it. As far as the NHS is concerned, the NHS is effectively the world's largest insurance system for healthcare. If they think it makes sense to do it, so if they think they can save money in 5 years' time by detecting something today, the NHS will do it.
There are, there's the heel prick test.
Yes, there is. That's a one-off one, of course, the heel prick test. Yeah.
It's a screening test.
Yeah.
for newborns.
Yeah.
Just different. In the US, they do.
Yes, I'm aware that for some reason, some healthcare organisations in the US do like calling people back every year for their height, weight, blood pressure, and a whole series of blood tests. Other than potentially denying you treatment further down the line for something they don't want to treat you, I can't quite see why they're doing that. You'd need to ask United Healthcare that one. Any more?
So they do the NHS health check.
Yes, the NHS Health Check is a weird one. The NHS Health Check isn't officially part of the NHS screening programme. The NHS Health Check also isn't an NHS Health Check, it's an Oxfordshire County Council Health Check. It's paid for by Public Health and Oxfordshire County Council. Again, it's another one that's labelled with the blue logo with white NHS written on it, because everybody trusts the logo, don't they? It's not nothing to do with the NHS whatsoever. We offer it in the building because people pay us to do it. So if they're going to pay us to do it and give us the staff to do it, we're going to offer it to the patients. This is supposed to be looking for cardiovascular disease and treating and preventing cardiovascular disease. It's not entirely clear whether any of these numbers actually add up anywhere at all. And we're not entirely convinced about any of this at the moment. We will see how it goes in the long run. Most of it's happening because somebody in government reckoned it was a good idea.
What's the frequency on it?
The NHS Health Check is done every 5 years, starts at your 40th birthday, the thing they call the NHS Health Check. And if you want one in the Whitehall's medical practice, you're welcome to ask for it. It ends at 74? Yeah. I don't know where those numbers came from. They were largely made up by a Secretary of State for Health on the back of an envelope. Perhaps on the back of his fag packet, depending on which one it was and whether he was smoking or not. There's a lot of debate as to whether it works or not. It doesn't meet any of the criteria of the NHS health check. But, you know.
I suppose we don't feed in the right information, so somebody doesn't give you when you go for those health checks, and you don't pass on the information that you're asked correctly, then it's not going to feed in, and you're going to get these positives and false negatives.
Yeah, that's what's going to happen. The NHS health check produces all sorts of weird results and false positives and false negatives, and then we have to spend a lot of time in general practice digging people out of the hole they've got themselves into because they've got a false positive blood test back.
Are there any screening programs that are triggered by other functions? I'm thinking that for diabetes, I'm surprised that there isn't a screening program for diabetes for people when they cross a certain BMI.
Yeah, good question. The answer to that is, again, the maths don't entirely add up. It's not clear whether patients who are obese should be having diabetes screening every year or not, and whether treating their type 2 diabetes, if they develop it, actually makes a difference to their life expectancy. Because, of course, obesity is associated with breast cancer, bowel cancer, esophageal cancer. There are a whole bunch of other issues that go around this. So actually, would they have died from natural causes without their diabetes causing them too much grief at all? Who knows, is the answer to that question. The numbers are still being worked out. There isn't a national diabetes screening program for the obese as a result of that yet. It wouldn't surprise me if it happens, but we haven't quite got the numbers in place to work out who, how often, how frequently, and with what test. Not the least of which, actually, to diagnose diabetes, you need 2 positive tests. So it's not 1, it's 2. So that makes it even more tricky to do. Cool. Any more for any more? Oh, we've gone over time again. You ask good questions. You're great. Cool. Okay. Well, in that case, we'll probably best stop it there. Then. Yep.
About general like blood test or hemoglobin, iron or something that for women, like some symptoms. Because I generally from Ukraine, we used to have tests
for everything.
And things like this, and it's always question.
Yep. The Americans did like selling you their blood test, didn't they? Yes, no, the bottom line here is no, we don't routinely do any of those unless the individual has symptoms of an illness. If the illness is present in the population, so if the percentage of the population that has the illness is up because they have symptoms which suggest they are likely to have the illness, the rate of true positives is much better for the test. So if you test people who have symptoms of an illness, you are skewing the test to be more accurate in them. If you test people who don't have any symptoms of an illness, you risk a high volume of false positives and false negatives. So to get those true positives and true negatives, you need the people that you're testing to have a reasonable chance of having the illness. Now that reason could be 3%, 5%, 5%, doesn't have to be a lot, but it has to be more than the average in the population of 0.8%. In which case you're more likely to get false results than you are accurate results. So that's why we don't routinely test.
Tiredness?
Yeah, so if you've got symptoms, you're in a group where you are more likely to have the illness, it's worth doing the test.
You're not screening.
Yeah, you're not screening. What you're then doing is diagnosing an illness in someone with symptoms. Yeah.
And other question about like private laboratories tests.
Yep.
Is it available?
Yes, there are loads of them. This is Oxfordshire. There is a ton of them around here. All of the science parks around here have private lab tests in them. Officially, we can actually order private lab tests from the hospitals as well, both Swindon and Oxford, because we have an option to request those via the practice. It's a bit of a pain because they charge us for them and then we have to charge the patients for them, so it all becomes messy trying to get the money sorted out afterwards, so we don't like it very much. We're not a huge fan of doing an awful lot of private medicine. We're NHS doctors and nurses. We much prefer to do NHS work than we do private work. If we wanted to do private work, I'd own a private GP practice seeing private patients. It's an option, I could do it. The reason we don't do it is because we don't want to do that. So we tend to point people elsewhere. There is a private GP service in Oxford, so if people want private blood tests, the usual solution is to find a private GP and get them to order them. That's by far and away the best way to do it, because they'll tell you what the results mean as well then.
And usually by the time a lot of people have symptoms, cancer for example,
Yep.
it's too late. How do you get
Well, okay, so the assumption here is that there is an assumption that early diagnosis makes things better. That is an assumption in some cases. In breast cancer, in bowel cancer, in cervical cancer, it is very clear that early diagnosis makes a difference. In esophageal cancer, it probably does, but that's not well proven. In pancreatic cancer, it makes absolutely sod all difference whatsoever whether you diagnose it early or not, because there's just no treatments anyway. At least no treatments that seem to make a great deal of difference. And in prostate cancer, it doesn't seem to make a difference if you diagnose it early or not, because we've got massive studies of men where we've diagnosed the cancer early, but they're still dying at the same age anyway. So there's something of a myth about early diagnosis is always the right thing to do. I just push back a little bit on that one sometimes. Sometimes it's worth waiting for the symptoms to develop and then sorting it out, because medically that is the best option for the patient. If we had an early, easy treatment option and an early good test, we'd be screening for things and doing it already. So most of the times we're waiting for symptoms to develop because we can't do it any other way. Yeah, healthcare is not perfect. I tell my patients on a regular basis that I went to medical school, not Hogwarts. I have a medical degree, not a magic wand. Cool. Shall we end it there? Because I think my family are hanging around somewhere in Farringdon and probably are waiting for me.